way, in certain circumstances, it can be disastrous to some of this group of patients. So my topic, frankly, deals with this refeeding syndrome. So it is when you increase the nutrition following a prolonged period of starvation, you can result in RFS, which is refeeding syndrome. It will commonly occur in populations who are already at risk for malnutrition. It is potentially fatal if you don't treat it in time. It will result into electrolyte and metabolic disturbances. And most of the sequelae that you find with RFS is based on cardiopulmonary, hematological, and neurological dysfunction that results because of the electrolyte and metabolic disturbances. Now, there is a role of interprofessional teams in evaluating and treating patients with this condition. So RFS, if you read into literature in depth, you'll find that there are certain problematic issues when I read literature or when anybody reads literature on RFS. One, there is lack of high quality scientific evidence on refeeding syndrome. Most of the reports are either retrospective, observational, and they utilize variable number of definitions for defining this syndromic presentation. There is lack of standard definition, which is impeding the estimates of the incidence of RFS. This is impeding the development of RCTs. It is impeding the exact treatment or the effective strategies that are meant for RFS management. Hypophosphatemia, which is considered as a surrogate marker for RFS because it is one of the most common abnormalities you may encounter in RFS. But think of a scenario like renal failure. You may not find hypophosphatemia. You may find hyperphosphatemia. You may find hyperkalemia. Then what do you do about RFS in that scenario? So where is the diagnostic dilemma in that area? And does this surrogate marker apply for RFS in renal failure? So let's evaluate this and go further. Now, this is one of the most interesting starvation experiments that was undertaken by Ansel Keys somewhere in 1944. And this is a clinical study which was performed at the University of Minnesota. The primary objective was to starve healthy humans to a point of famine-like status and then study their physiological and psychological effects of prolonged, what is going to happen to their physical and psychological aspects. So basically you are starving healthy individuals over a period of time and then gradually either by exercise or by limiting the food, and then you are refeeding them and then assessing what's happening to these gentlemen. Now, doing such a study in current times will be considered unethical, but at that time it was wartime and people were given bait like if you participate in this study, you will not have to go for war. So there were many people who did come up, and out of that only 36 are actually eligible for getting this study done. Now, a lot of hue and cry was raised that why you starving people? They went from healthy humans to cachexic, really flesh and bone type individuals, and then a lot of physical data, physiological data, cardiovascular data, nutritional parameters were all assessed. So what you read in the RFS, this is considered as a very, very important nutrition-based study, which deals specifically on RFS syndrome. As I was telling, the incidence is so variable that whenever you read literature, you can't be very sure what is the incidence of RFS in the current literature. So it can vary from as much as say 1% to as much as 66%. So just see the amount of variability it has. And this is happening because definitions are not very structured, very clear. What has to be measured is not very clear. What will be considered as mild, moderate, or severe is not clear. And this surrogate marker, which we all consider, hypophosphatemia, may not be apt in all the circumstances. And therefore, this variability is there. But even if you read literature, you want to understand whether if somebody has RFS, whether it will lead to a higher mortality, whether it will lead to a higher length of hospital stay. So this was a study published in Internal Medicine and Gastroenterology Unit. So it did say that yes, you will have higher hospital mortality as well as a higher length of hospital stay if you have RFS. Further on, when I explored this topic, went into the systematic review and meta-analysis, I could find, this is one of the latest one that I could determine, the American Journal of Medicine, which talks on the effect both on short term, which is less than 1 month, and medium, that is less than 6 months mortality aspects if a person has got RFS. Now it deals with studies done in worldwide. So overall, they took 11 studies into this. There were both retrospective and prospective studies included. And they did find that this is the first meta-analysis that is there. It talks about short-term and medium-term, and it emphasizes on the need of nutritional specialists to treat these patients. So yes, it will have mortality impacts more in the trend is there, but for the medium term, there was significantly more data or more suggestive data that it will increase mortality. But for short term, there was a trend towards increased mortality, though not statistically significant as per as these 11 studies. So what is happening in refeeding syndrome? So let us start the curve, say from the right top end. If you're starved, if you're malnutrition, then there is going to be more glucose being produced either by the glycogen or by the protein breakdown. So there is a catabolic state, and therefore protein, fat, mineral, electrolyte, and vitamin depletions are going to occur, and there will be salt and water intolerance. And that means from a catabolic state, if you start to refeed an individual, that is, has to be a switch from a catabolic to an anabolic state. And when it happens in a patient who is already predisposed to malnutrition, there is going to be fluid and salt nutrients, and all of them are going to lead to an hypersecretion of insulin, which we know is an anabolic hormone, will lead to more protein and glycogen synthesis. And there'll be more glucose uptake, there'll be more utilization of thiamine, there will be more uptake of potassium, magnesium, and phosphorus within the cell. And this is what will lead to your lower levels in the serum of hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency, salt and water retention, which are all considered features of this refeeding syndrome. So this is the entire cascade from catabolic state to anabolic state. Therefore, as discussed in the previous lecture, that yes, you must feed these individuals. They're catabolic, you must feed them. But there is a certain group of patients whom you'll have to be a little slower, you'll have to be more cautious in what you do. There are certain predisposing conditions for this refeeding syndrome. If you look at, it's difficult for me to memorize any of it. So my take is anybody who is at risk or already is in malnutrition is at risk for having a refeeding syndrome. So you read all those causes at the back and you'll find that, okay, they are all predispositions to malnutrition. Therefore, any patient in whom you want to really start nutrition has a risk for malnutrition, he is a potential candidate to develop a refeeding syndrome. What are the signs and symptoms? So as I told you, it is mostly related to the electrolyte abnormalities and thiamine deficiency and the water retention that one may have. So hypophosphatemia signs and symptoms will be there, hypokalemia, hypomagnesemia, thiamine deficiency, and sodium and salt retention, fluid retention will be there. But if you closely look at some of these features, there's something striking about it. Most of them will have neurological related issues. Yes, there are cardiac also, but predominantly, if you see, I've just marked them, they're all neurological features. Hypophosphatemia, the top ones are all neurological. Hypokalemia, the top 3 neurological. Hypomagnesemia, the top 6 or 7 are all neurological. Thiamine deficiency, almost all of them are neurological in nature. So for clinicians who are feeding these patients, just have an eye on some of these features, which will start to come. You're about to feed these patients in the usual routine manner that you do, and you will probably have these symptoms coming up in these group of patients. So just be careful. So ASPEN came out with the consensus recommendations for refeeding syndrome very recently, and I'll just elaborate on some of these things in the coming few slides. So they have now stratified diagnostic criteria for RFS. That means you must have a decrease in any 1, 2, or 3 of these serum markers of phosphorus, potassium, and or magnesium levels. So it could be 1, it could be 2, or it could be 3 of them, all 3. If the fall is 10 to 20% from the normal, it is mild, 20 to 30% moderate, And if it is more than 30% fall and or associated with an organ dysfunction, which results from a decrease in any of the above and or due to a thiamine deficiency, that too occurring within the 5 days of reintroduction of calories. That means if you look at the last line, that means I will start my nutrition in the usual nutrition, and then I have to be careful in the first 5 days. And then I will have a diagnosis of RFS, and then I will start managing it. Looks a little too slow for me, occurring within first 5 days of reintroduction of calories. So why am I not careful on the day one when I'm about to start? So that means you need to risk identify them beforehand so that you don't have to face an RFS. So there are some moderate risk factors where 2 risk criteria are needed. And then there are significant risk factors where only 1 risk criteria is needed. So this will help you identify even before actually a patient lands into RFS. So there are 7 of these points highlighted on the left-hand side of the left-hand corner. Highlighted. The BMI, you need the body mass index, the weight loss. What is the weight loss over a period of time? The calorie intake, what has been the calorie intake over the last 5 to 6 days? So here you are trying to risk stratify each patient on whom you start a nutrition program. Okay. There is abnormal pre-feeding values of potassium, phosphorus, magnesium concentrations in serum. There is loss of subcutaneous fat. There is loss of muscle mass. There is a higher risk of comorbidities, as was told in the previous number of list of conditions which I told you. So then you try and risk stratify your patient, whether it is a significant risk, whether it is a moderate risk. So this is a strategy to help you. So what you don't know in your mind, you won't see it in the patient also. So just be aware that when you do start feeding in a malnutrition patient, yes, you want to early achieve the targets, but here is a trap which you should be aware of. So just recategorize your patient, whether this is a risk factor for RFS or not. So let's look into guidelines. What do we do? How do we do? How do I plan my initial calories? How do I feed the advancement programs in feeding? And what are the other recommendations? So there are guidelines from NICE, from Irish Society, from CNST, CRAE, and Fredali, who have looked into these things as to how it has to be done. This is what we have been doing over long periods of time. It is only now that the ASPEN has more categorized it, more stratified the diagnosis and the plan of action, which I'll just elaborate in the next slide. So what we have been doing now is the highest risk patient or the extremely risky patient, I will go with 5 kilocalories per day. Okay, just imagine 5 kilocalories per kg per day. This is our target. I may play up to 10 kilocalories if it is a moderate risk patient or little less. So the range is 5 to 10 kilocalories. Normally, I would feed him around 25 to 35 kilocalories. If I am not including the proteins, then it will be around 25 kilocalories. If I include the proteins, it will be around 35 kilocalories. That is a normal style of writing for kilocalories for my patients. And then how do I advance? So it has to be slow. So one thing I have done is I've reduced the calories. Second, I have reduced the time frame in which I want to achieve the targets, my targeted calorie goals. So for easy to remember, I'll say 7 days. So my target is for reaching the target goal is 7 days. So in the next 7 days, I will try and reach the target calories. So there will be a percentage escalation, which I do for every patient. It may vary depending on features of dyslipidemia that this patient may have, how severe it is. Then other recommendations include, I need to restore the circulating volume. Okay, this is the previous, all guidelines were suggesting, yeah, I have to restore the circulating volume. I have to check the electrolytes. I have to consider all sources of calorie. Remember, I write a lot of calories unknowingly to my patients, all dilutions, sometimes in 5% dextrose. I'm giving propofol. I'm giving other sources of energy to my patient. So I need to compute how many calories is actually going. When I write, I'm thinking only of the enteral nutrition or on the parenteral, but there are so many of other infusions which are going. Drug dilutions, I do not calculate them when I write my prescription. So in this scenario of RFS, it is better to be more careful than sorry. Then a fluid restriction strategy is advised because, as I told you, RFS is a fluid. There is a lot of fluid retention. So if the patient is not hemodynamically unstable, then my fluid would be around just a liter per day initially for severely malnourished patients. So this is the normal strategy. Now, what ASPEN is going further ahead is into, again, those four acids. What is my initial calorie? What is my fluid restriction strategy? What is my electrolytes? What is thiamine and multivitamins, and monitoring? So just there's so much of to read. So I've just pointed out, I'm sorry for this busy slide, but I've just highlighted the ones you should remember. So you initiate this patient who is identified or at risk for this RFS. You initiate only with 100 to 150 grams of dextrose, or just 10 to 20 kilocalories per kg for the first 24 hours. And you advance by 33% of this goal every 1 to 2 days. So for me, it will be every 2 days, I will just escalate by 33% and try and reach that target within 4 to 7 days. So this is one strategy. Second is aspects which were previously told: fluid restriction, sodium restriction, protein restriction. There are no recommendations from the ASPEN to do any of it. So there is no fluid restriction mentioned now. There is no sodium restriction which is mentioned. There is no protein restriction. So there are no recommendations on these three aspects for the treatment or for patients of RFS. What do I do about the electrolytes? So I need to be careful. So check them, check potassium, magnesium, phosphorus before you initiate the nutrition for this group of patients, at-risk patients, and then monitor them more frequently. The more severe a patient, the more monitoring he'll require. Otherwise, initially, it will be at least 4 hourly to 6 hourly to 12 hourly for some of the extreme risk RFS patients. So the intensity will change depending on the severity of the dyselectrolemia you have. Thiamines and multivitamins have to be supplemented mandatorily. Supplement 100 milligrams of thiamine before feeding or before initiating a dextrose containing IV fluid in patients who are at risk. And then you can supplement them by 100 milligram per day for the next 5 to 7 days. You can increase it further depending on the background, say if he's severely starved, chronic alcoholic, or there is a high risk for deficiency, and or there are signs of thiamine deficiency. Measuring the levels of thiamine have not been found to be very useful. So just give it. That is, I feel, more easier than actually quantifying thiamine levels. Then you have to monitor for long-term care. Now, recommended vital sign monitoring for the extremely risky patients is every 4 hourly, but you, depending on the cardiovascular, respiratory, and other organ status, you need to monitor it accordingly. So there can be no fixed formula where how you do it, but it depends upon the stability of the patient. Then you evaluate both short-term and long-term goals of nutrition care daily during the initial days of starting nutrition in this patient. So now nutritional assessment, which you had, आपने start किया nutrition for a normal malnutrition patient. So you have to do it probably daily in the initial stage for some days. At least for me, it would be the first 7 days. I need to be very careful how I start the nutrition in these RFS patients for the first 7 days. So my boundary wall is 7 days. I'll be more judicious in giving fluids. I'll be more judicious in estimating the electrolytes, monitoring the electrolytes. I'll be more judicious in how much calories I'm giving him, what type of calories I'm giving him, and then I gradually escalate. So this is the strategy for all RFS patients who are at risk for in adults. There is pediatric guidelines also, because I'm an adult physician, so I'm not talking of the pediatrics, but the same article also gives you pediatric elements. It will be there'll be more tightness in that. That is the change that will be there. So what is the future research? Okay, now since there were nothing defined previously, now it has been defined. There are criteria, so more studies can go on, more randomized trials can go on, and a different set of populations need to be assessed, say renal failure patients, liver failure patients, ICU patients, non-ICU patients, general patients, anorexia nervosa patient. That is the standard for study variability. And anorexia nervosa patient, now you have to refeed them. So very high risk for refeeding syndrome in that group as well. Those in the ICU, adults may behave differently, adolescents, children, neonates, there will be a huge level of elements. I would encourage all the students who are part to this presentation that they can start projects on RFS. They can have studies published, because whatever is available in the consensus is yet to be validated. So these criteria can be validated in different subset of populations. So here is a research field that is ripe with possibilities. So studies are required to compare these, and prophylactic electrolyte supplementation, again, a controversial area, but if there is extreme risk and the electrolytes are very low, it is wiser to correct them before I initiate them, because it will dip further and I'll have more problems. So again, it has to be studied, but common sense says better to correct them before you initiate that nutrition. So to summarize, I would say RFS is a reality with variable incidence, potentially fatal if you don't treat it in time. Risk stratification is needed to identify the patients better and plan the nutrition strategy more judiciously. Consensus criteria by ASPEN need to be tested by RCTs. Therefore, I'm saying there are studies and projects that can be designed for RFS in different clinical scenarios in the institute. And there is future research can be designed based on them and provide more valuable directions. Till then, use them to prevent and treat RFS in a more better way. Thank you.